Welcome to CME number 923. 923 continuous uninterrupted CME over last 20 years.
Dear friends, I am delighted to moderate yet another CME given by Dr. Rajashekhar Reddi. I remember most of the CMEs given by you. I was the moderator, sir, and I am delighted again. It's a coincidence that we all are ready to listen to a CME given by Dr. Reddi, and moderator is Dr. Reddi. So, clap for him. Sir, when one of my duties to introduce you, and I don't think you need any introduction to our group. We have been listening to you for so many years, at least from 2012 onwards, but I remember many of the CMEs are on my tips, and you are one of the principal consultants, head of unit, and have at least half century of publications, and you are really close to our friend circle. You are one of us. You don't need any introduction. One comment I can make: you are one of the most handsome clinicians I have ever come across. And Dr. Chauhan always says, "Isharon isharon mein dil churata." मेरी जान सीखा है तुमने कहाँ से? This is only given to you, sir. My pious duty to introduce the topic neuromodulation. When I was given this topic on the WhatsApp group, I was reminded of traffic policeman. What a traffic policeman does, modulates or regulates the traffic. And I was also reminded of ECT treatment given in, say, 50 years back. I saw first time ECT treatment, electroconvulsive therapy given to a psychotic patient, and a CDOC therapy. Then we came to know about transcutaneous magnetic stimulation, Cmes, for so many things, migraine one of them, depression and other things. So today we are talking about the devices which are very much on the rise. There are at least 5 devices approved by FDA, and one of them we will be focusing more, which Dr. Reddi also has a part in it, and it will be my duty to introduce that there are devices to modulate nerve functions. It can be for pain, it can be for other things. I am also reminded of some magnetic beds which are thought to be good for sleep. They have been marketed. So all to you, sir, please enlighten us for newer devices which are used for neuromodulation, means regulation of the function by a device. And they are usually paired with the mobiles. Sir, thank you so much. Welcome.
Let's hear it for the best neurologist.
Thank you, sir, for the very kind introduction as always. And again, very grateful to this group. That's about 20 years of being neurologists in South Delhi. And I think that all of you are familiar faces now. I'm very grateful to all of you. You've supported my journey till now, and I sincerely thank you for that. I think Dr. Chauhan was saying that this is the 923rd. Possibly I may have joined when it was about 70, 80 or something, I'm not sure. I certainly wasn't the first few here, but I was there around that time. So
2010, sir, you joined us.
Sorry?
For the CME, 2010.
2010. Alright, so it's about 15 years, which is also a great time. So thank you so much, and I really want to thank all of you for that. Also, Dr. Reddi's labs for this program today, because as you know, that these days it's not that easy, and we've got these people to support us, and I'm grateful for their benevolence today. Thank you for that. So I'm going to talk about a very common topic, and we know that all of us are seeing patients with this problem. So they know it's not like this is a neurologist's problem. And we don't have enough neurologists in this country to manage everyone's migraines. We certainly will not have them for the next 20, 30 years. We will not have that. So we need people who are taking care of patients, good doctors, to be able to manage this problem. And I'm saying that I'm 100% certain that all of you, each of you are probably seeing more migraine patients than I am. I'm pretty certain of that. So I think it's important for us to understand that there's been a journey, and we have a lot of old medications which have been going on. And it's not that they're not useful, but they are repurposed drugs. Now we have a little more specific medications, specific devices, which are there for treatment of this very common problem. So I think it's important for all of us to be able to be shared one of all that knowledge we have, and plus to be aware about it also. Because, like Dr. Kalra was saying that modulation, this word modulation. So we use it very conveniently. Neither are you suppressing anything, neither are you stimulating anything. So you're modulating stuff. When you talk about an immunosuppressant to a patient, the patient is worried immunosuppress ho gaya. Or immunostimulation ki baat karte hain, then he feels happy. But when you use a sort of a neutral word like modulation, it works very well. And I think that these devices have that property. They're not doing anything bad, they're doing good stuff, they're not suppressing anything, not stimulating anything. So this is a good modality of therapy. I'm going to talk you through a little bit about migraine and then about this particular device itself. So I'm going to first one or two things about what is migraine. So you broadly divide headaches into two categories: primary headache disorders and secondary headaches. Primary headache disorders are typically headache disorders in which there is no underlying structural pathology, but they have headaches. And you have secondary headache disorders which are because of something in the brain which is causing a headache. For example, a space-occupied lesion like a tumor, or let's say an infection like a meningitis. Now, if that is the cause of a headache, it's called a secondary headache disorder. Now, if you look at all the headache disorders in the world, primary headache disorders will be 99.9% of headaches. Less than 0.1 headaches are because of secondary headache disorders. So the moment the patient comes to us, the first worry is, oh, is there something bad happening in the brain? But typically what happens is nothing really turns out. And we are dealing with it. And patients find this quite frustrating. Because they kuch to hoga, why am I having so much pain? But we have to start with the premise that there isn't going to be anything very much, and the patient needs to be told we're doing tests to rule out bad stuff, which is a minuscule of the percentages of problem-causing issues in the brain. Okay, so now I was just having a discussion with some people there, and he was telling me very interestingly that if you have a headache involving the whole head, it can't be migraine. It's always one-sided, and it's not monocrinial. So yes, so he raises his hand there to tell me. And so if you look at migraine, the word migraine comes from the word hemicrania. Hemi means half head, half cranium. But only 60% migraines would be unilateral. Most people would say 40% are bilateral. And some people would say as much as 60 are bilateral, and only 40% are truly unilateral. And of course there are other criteria which go with it. But when I'm talking about these primary headache disorders, which are largely migraine, there's a small proportion of patients who will have a tension type headache, who will have what is called a TAC, a trigeminal autonomic cephalalgia, which is a cluster headache, which is a prototype of a trigeminal autonomic. And there are other things. I will not go into the details of episodic paroxysmal hemicrania and a chronic paroxysmal hemicrania and a sunk and this and that. But a cluster headache is something that I'd like everybody to recognize. Some patients will come, it will be typically a man. This is the only headache disorder which is more common in men. 9 out of 10 people are men who get cluster headaches. They have one-sided headache, typically it's a orbital, periorbital pain. It's called an alarm clock headache because it occurs in a stage of sleep which is called the REM sleep. So people wake up with a headache. They typically will have autonomic symptoms which are watering from the eyes, a runny nose, and they're usually very restless in the day. So I'm just throwing it out there to tell you that even funny-looking headaches are sometimes only primary headache disorders, not secondary headache disorders. Now, how do you diagnose a migraine, which is a commonest type? You classify them into two categories. Anybody who has headaches less than 15 days a month is called an episodic migraine. Anybody who has headaches more than 15 days a month is called a chronic migraine. Now, even this first 15 days is further subcategorized. If you have 1 to 3 headache days a month, it's called a low frequency episodic migraine. 4 to 7 headache days a month is called a moderate frequency episodic migraine. 8 to 14 days is called a high frequency episodic migraine. Now, I'll tell you why this is important, because when you write these things down on a patient's prescription, you might see a person say, "Mahine mein kitne din aapko takleef hoti hai?" So he says, "3 din hoti hai." So you write 3 and you write LF here. After 6 months he comes back and you write, now he's got 8 out of 30. So he's gone from a low frequency to a high frequency. So you might want to change therapy, you might want to see what is happening, and all these people are going to require evaluation of his lifestyle. A lot of other things need to be done. Are there any triggers that you need to look for? All those things also need to be done apart from the treatment. And I know that all of you are probably doing that. You're going to tell them to have sleep hygiene, limit their caffeine, look at triggers and try to avoid those triggers. But once you start reaching this moderate to high frequency and the chronic migraine, therapy is recommended. In the low frequency episodic migraine, let's say 1 out of 30 days a month, you may say just an SOS medication works. And this is important to understand because of that. Now we know that headache is, this is the commonest problem in the world. Okay, we will tell you today that out of 7.5 billion people on this planet, 1 billion people have migraine. Okay, so that's a lot of people, right? And they're obviously underserved. We don't have enough doctors, we don't have enough neurologists, we don't have enough physicians to take care of this. There's a lot of functional impairment. And me, because I get to see the bad ones who come to me, I will see a lot of social problems because of this disharmony between spouses, a lot of women who will come and tell me that their mother-in-law is there after them. I'm sorry to be so stereotypical about such a thing, but it is a common problem in our country. People will say, she's not working, or she's got this problem, she goes and lies down, and she's got a headache, and it can be incapacitating. The sonophotophobia that you get in there, the sounds irritate you, noises irritate you, and every movement of your head can be jarring. So it is something which is quite troublesome and quite serious. So you must recognize that and not just pass it off as just a headache. Now, what is the pathophysiology of this? I won't go into too much details because the next few slides are that. But basically, there's brainstem neuronal hyperexcitability. There's CSD, which is cortical spreading depression. These are various theories. There's abnormalities in various neurotransmitters such as 5-hydroxytryptamine, what is called a calcium gene-related peptide, noradrenaline, dopamine, GABA, glutamate, nitric oxide, and endorphins. And there's obviously trigeminal activation. We know that the entire head is supplied by the trigeminal nerve. Sorry, was I not loud enough? Sorry. Okay, so what happens is this. You can look at this flow chart. There's pre-symptomatic hyperexcitability that increases brainstem response to triggers. There's the release of these neurotransmitters I spoke of. Neurotransmitters activate the trigeminal nucleus. And there's a dilatation of blood vessels which results in throbbing. There's activation of certain areas in the brainstem which is called the area postrema and the chemoreceptor trigger zone, which results in nausea and vomiting. There's activation of the hypothalamus that results in hypersensitivity, like you touch your scalp and there's pain. There's activation of the cervical trigeminal system, which causes neck stiffness, muscle spasms, and of course activation of the cortex and the thalamus that result in head pain. So all these things are happening. So as a result of the understanding of these pathophysiologies, we know that there are chemicals. Of course, we give medication to try and sort the problem out. But we now also have certain unique, newer ways to try and deal with this problem. So, look at this flowchart again. We've got all these treatment options. Pharmacological, we're not going to discuss today. Non-pharmacological include migraine devices, which are invasive or non-invasive. And you can see this gamut of options available now. We have supraorbital stimulation, we have vagus nerve stimulation, we have transcranial direct current stimulation, occipital nerve stimulation, REM, which we're going to talk about today, kinetic oscilloscopic stimulation, so a lot of things which are there now. Now, these are a few of the things we're going to talk about today, which is Kefali, there's a device called gamma cord, Nerevio, and this is a transcranial magnetic stimulation device also, which is called Neura, which is available now. And there are 5 devices like Dr. Kalra mentioned. One of them It's called Relivion, which is very new, and we won't discuss that today. In the interest of, I know the topic is about Relivion, and to my mind, among all these devices, it's the only one with a unique mechanism of action. So it's just that there are so many others which are there right now. It's important to understand that this is not a one-off thing. There are so many other people also actually investing in this and realizing that this is a potential option for treatment for this condition. So how does Kefali work? Kefali is a device which is placed in the forehead. It's approved by the FDA for treatment and prevention of migraine in patients more than 18 years of age. It stimulates the trigeminal nerve, and its side effects are sometimes a little bit of irritation and fatigue after the treatment. There's a device called gamma cord, you stimulate the vagal nerve, and this again, you can see exactly where it's positioned, and you use varying intensities to try and stimulate the vagal nerve, and again, sometimes redness, facial twitching, nasopharyngitis, and if you do too much of vagal stimulation and the vagal tone goes up, you might cause a symptomatic bradycardia, which is not very common, but it can happen. This is a transcranial magnetic stimulator, which is called the E-Neura, and this is how you hold it. It disrupts what is called the CST, which is thought to arise in the occipital lobes and go anteriorly. Its side effects are lightheadedness, tingling, tinnitus. So, how does the device, which we're going to focus on today, work? This is the REN device, and what we need to understand here, and I'm showing these two charts to show the difference of how the devices and the medicines actually work. When you talk about pharmacotherapy, there's the presynaptic trigeminal nerve terminal and the postsynaptic terminal, and then you have the blood vessels. And I'm not going to go into the details of which chemical acts where, but I'm not sure that people are going to be very interested in where triptans act and where GPANs act and where monoclonal antibodies act. But most of them are acting in that area to try and block the cascade of chemicals. Now, how remote electrical neuromodulation works is, there is something called central pain modulation. There are these signals that go down from the brainstem, and this central pain modulation is thought to be inhibited in patients with migraine. So what this device does is sort of upregulates that and brings it into play so that the pain of migraine can be taken care of. It's a very simple way, and I will show you some evidence for that. So here's the pathway. You have ascending projection. The spinothalamic tract sends projection into multiple brainstem areas, and there are descending pathways which are trying to modulate that pain. And these include two areas, which is a very active purple gray, and what is called the rostral ventral medulla. Again, anatomy, you don't need to know all this stuff. But this is what I wanted to tell you. This is the way it works. This is called conditioned pain modulation, and in various studies, it's been seen that people who have a disordered conditioned pain modulation will have more chronic pain. And this dysregulation is seen more in patients with fibromyalgia, with tension type headaches, with IBS, with electromagnetic joint disorders. And if you have a low CPM efficiency, it suggests that there is low pain inhibitory capacity. That's what happens. So again, the mechanism of action, as you can see there, and you have the ascending pathway which goes through the A delta and the C nerve fibers. The REN stimulator starts acting on the C and the A delta fibers. So as it goes up, it stimulates the same pathway. There's a descending central pain modulation that comes into play, which is being sort of not working in this particular group of patients. And the moment that happens, this device starts giving patients relief from headache. So as early as 2019, this has received a de novo authorization by the FDA, and there was an expansion of indications in 2023. So this is an FDA-approved device from the year 2019. It's 6 years of approval in the US. It's available all over the world, including the US, in Canada, in Europe. So it's not something which is, I shouldn't say in Chinese, but I'm just saying that it's approved all over the world. So we have a demonstration of the device after this? Yeah, okay, excellent. So every device is good for 18 treatments. After that, it is sort of reloaded. Every treatment session lasts for 45 minutes. This is completely drug-free. This particular device, there is nothing. And this is approved for anybody who has an acute headache and it's also used for preventive treatment of migraine with or without aura in patients who are 12 years and older. What you do is you place the device on the arm, you start the treatment in an app, and you remove it after 45 minutes. So again, details of the kind of pulse frequency, pulse width, etc., whatever is being used. And I just want to tell you that basically these are patented electrical parameters. But by and large, what they're trying to tell you is that there's a particular frequency that one wants to use. So if you use a very high frequency and it becomes painful, then it's not efficacious. So when you start using the device, it starts with intensity. The least intensity is 12%. And you're ideally supposed to go up to about 34%. But anything between 25 and 45% works fine. If you start using 80%, 90%, then you're stimulating nerve fibers, and that's not how this device will work. So you have to use a particular threshold below which you stay and above which you will stay. With which, and this is an easily settable thing with your phone. So they'll just show you how that works. So what are the clinical trials? Just like all medications, this has been tried in headache trials. The structure of these trials is exactly the same as one would do for drugs. So this was done in 7 sites in the US and 5 in Israel, because this is a device which is actually produced by Israelis. So these people obviously would have the trials in their country. The number of patients were about 252, intention to treat population. There were 202 in the final statistical analysis. And there were there were primary endpoints and secondary endpoints like any other trial. For pain relief, they looked at improvement from a moderate or severe pain at baseline to a mild or no pain, or improvement from a mild pain to a no pain baseline. So this is for pain relief. For pain freedom, they looked at from a severe, moderate or mild pain to going to no pain. So they looked at pain relief and pain freedom, and they also looked at relief from what is called most bothersome symptoms. MBS typically in migraine trials is used for nausea, vomiting, the unease that goes on with the typical migraine. So you can look at the outcomes 2 hours post-treatment, and you can see the difference between the sham and the device. So pain relief was seen in as many as 66% as compared to 38%. And I want to show you that whenever you see these bars, you see that there is some placebo response. All pain trials will have placebo responses. So there's some suggestibility in pain, unfortunately. And so one of the things that all of us have been always taught that if a person responds to a placebo, he's not always faking the pain. So there is, this trial, like any other pain medication trial or pain device trial, shows similar outcomes. But you can see significantly better outcomes in patients with pain relief, pain freedom, in most bothersome symptom relief, certainly there. Most bothersome symptom freedom was not too different, but still more for the treatment. And if you look at all multiple treatments that were given, you saw that with the active, with the device, people did much better. You look at the adverse events, there is no specific worrisome adverse event. At best, because you're putting a device on the forearm, on the bicep, you would feel that sometimes there's a little bit of itching or scratching in that area, some sensation of warmth. But nothing that ever causes a discontinuation. Nothing at all is happening. And that was, for various things. We use it for both for acute as well as for preventive. In this study, they looked at the use of the device for about 2 months. At the end of 2 months of intervention, in patients who use the device adequately, they looked at the mean reduction in the monthly migraine days. We call them MMD. And I keep encouraging people that whenever a person comes with headache, ask them to maintain a diary. It's important for them to write down how many days a month they're affecting. If you don't do that, you'll never have an objective quantification of whether they are better or not. So in this, again, you can see on the extreme left, as compared to the placebo, there was a significant net gain of about 2.7 days per month in the patients who were using this for preventive treatment. And again, in the episodic and in the chronic migraine, in both the things, it was seen that it was better. It was also seen to be improving moderately severe headache days, all headache days. They also look at something called usage of acute medication days. So how many days did you actually have to take an acute medication? Was there an improvement in that? And strangely, the only adverse effect they reported was one patient who had a chronic pain syndrome, fibromyalgia-like, who actually complained that there was an increase. But this device is actually now being tested for fibromyalgia. If anything, it's going to help with that. So this is just one of those odd things. And as you can see, adherence was very good. Almost 90% patients completed this study, which means that there was no reason for them to drop out because they were uncomfortable. How quickly did it work? In acute migraine studies, it showed that within 2 weeks, you could get some response as compared to. So when you're trying a device also, if a patient tries it once or twice, you shouldn't give it up. You should say, look, you have to try this for at least 2 weeks. And if you're using it as a preventive therapy, but you're using it every other day, then you must give it for at least 6 weeks before you say that this is not working. So this is at least on the basis of studies. Now, this is a comparison of Neuromodulation, which is right at the far end, right away from me, and compared to all the top migraine medications for episodic migraine. Now it includes topiramate, which is thought to be one of the best medications. It's got the newer, what's called middle molecules, which is rimegepant and atogepant. And then there is this group of monoclonal antibodies, 4 of them. And you can see that what they've seen here is the net gain, which means that as compared to the medication and placebo, what is the difference in the number of days that you gain per month? And you actually see the largest gain is in Neuromodulation. And this is for like monoclonal antibodies like eptinezumab and galcanezumab and fremanezumab and erenumab, which are all at the moment the cutting edge of migraine preventive and acute therapy. So in that it has worked that way. Now that is for episodic migraine. And even in chronic migraine, I'm telling you that chronic migraine patients are a difficult group. They have more than 15 headache days a month. I have patients who come to me with 30 headache days a month and they're popping 5 vasopressins a day or 10 sumatriptans a day. And you're talking about 500 pattas of this going off in 3 months. So, and all these patients are going to be at very high risk of stroke. So they have a medication overuse headache with chronic migraine. They're very high risk of developing a heart attack and so many things. So these are the patients who are going to be difficult to treat also. Because even if you do anything, it's like I always say the most toughest patients are the least likely to respond even to your best medications, even though they deserve it the most. Because inherently the disease is that bad. But even in that group, as you can see, you compare this to onabotulinum toxin, which is Botox. You've got these 4 parts of these monoclonal antibodies, and you've got Neuromodulation. And you see that the net gain was actually most in Neuromodulation, which is interesting because the others are thought to be now, like the moment you get into a headache clinic in the US, they don't talk about any amitriptyline or any beta blockers and all that. The moment they see you, they diagnose you with migraine, you fit criteria, and you straight go into monoclonal antibody therapy. It's as low end as that now. They don't believe that. They say that there is a migraine-specific medication available. Why would you want to give a repurposed drug? Why would I want to give you an antihypertensive or an antidepressant or a beta blocker? They don't want to do all that anymore. Now, this is again a very interesting category of patient. So we often will end up getting a referral from gynecology, and they'll send a patient who's 3 months pregnant or 4 months pregnant. And obviously, even if you're 7, 8 months pregnant, you really don't want to be taking any medication which you don't absolutely need. And some of them are suffering from bad headaches. And now, this is a situation again where such a device comes very handy, because you don't want to give any medications for fear of side effects. And even if you think that there's a medication which is safe, there are certain which are safe, or relatively safe. But the family and the patient themselves are not very keen with it. This is something that works. So this was a study done in Stanford, and they compared RED to controls in a fair number of patients. There were about 60 patients in the study, and they found that all the secondary endpoints, which were basically looking at newborn birth weight, miscarriage rate, preterm birth weight, birth defects, developmental milestones, the need to come back to ER for any kind of emergencies, was no different in the treated group and the untreated group. So the safety is absolutely well established. That's something that I wanted to sort of tell you. So if you look at this thing, this is a very interesting way to plot whether a patient benefits from a drug or not. And you see that on the x-axis is a dropout due to adverse effects on the left side of the screen, and a change in the monthly migraine days versus placebo. So the lower down you are on the y-axis, the better off you are. And the further you're closer to the zero, you're better off in terms of the lack of side effects. So here you can see the review and the CGRP monoclonal antibodies on the bottom of toxin, you see topiramate and the CGRP only. Because those are the ones that are approved for chronic migraine. So I want to tell you that the efficacy, the safety is very sort of well expressed by this single slide, both for acute as well as for chronic migraine. So you select the patient appropriately. Like I said, you must not misdiagnose the patient. Everybody would, so I know that as a private practitioner, I end up imaging everybody. And I'm sorry to say that, but invariably if a person has come to me, I sometimes have to tell them, there isn't anybody else you can go to after this, so I have to image you to make sure that we're not missing anything, even if there's a very minuscule chance of picking up anything, unless you've already had imaging done. So I will have to do imaging for most people, but patients who had headaches more than 15 days a month that's an indication for imaging. You must do that. There's no question about imaging that group of patients. So this is how you write a prescription these days. You write that patients have headache for last 10 years, more than 10 days per month, limited response to whatever drugs are being given. The diagnosis is episodic migraine with aura, and here it is moderate high frequency episodic migraine. You advise topiramate, you start low, go slow, and you write there, consider the review trial if no further improvement. And the patient's back within 6 weeks, not much better, and you say that go ahead and start the review straight away, break the cycle of pain, and we'll see after that how the patient does. So this is right at the beginning, that discussion should happen. You may or may not have to use it, but it's important to introduce the topic, important for the patient to go and read up a little bit about stuff, and that also helps them gain confidence that these are not things that, otherwise nobody's ever heard of these things. So it's important for people to sort of, for physicians and for neurologists to be telling patients that these are the options. So I'm not going to go through this slide, this is just a comparison. The right side is where you see, this is a single slide showing all the new neuromodulation devices. To summarize, this is an appealing option for migraine management. It was introduced in India in 2023. It's been evaluated in 2 randomized controlled trials, 1 open label study, and more than 19,000 patients have gotten this device here. Patient selection counseling is important, and this is a very, very advantageous option where you're using conventionally, you're trying to use drugs. This is something which is drug-free, and another patient, it's sort of not very, it's not obtrusive, it doesn't cause any embarrassment. The e-Neura device I thought was a little bit much to hold that behind your head. You can't be doing that in office, but this is just to wear around your arm, and you can use this at a workplace, you can use this when you're traveling, you can use this in a family function or whatever, and nobody's ever going to know. So I think that this is a very attractive option, it's a very effective, a very safe option. And I think as time passes, when we use this more and more, you would have a little bit of sense of comfort in recommending it, and the patient will come back and tell you, if they're not better, they're not going to use it anyway. So sometimes, time will also tell us. And if patients are going to get better, they will always come and tell you that they're better. So there's no reason for patients to lie. So thank you everybody for a very patient listening, and very kind of all of you to be here. Thank you.
Dr. Reddy sir, please come here. We will open the bar, but we will serve you on the table. Please don't go there. The boy will come to you, just order your drink, and you will get it. I think it was a very, very illuminating talk. I would give it to my moderator, chairperson, Dr. M L Kalra sir, for his perspective, and then to my panelist, Dr. Shukla, and then we will ask questions. I'm sure many of you would have questions. Kindly note it down. I will come to each and every table, and then you can ask your questions. Dr. Kalra sir.
Dear friends, yet another masterly talk by our favorite speaker. Sir, what I could gather from all your elaborate talk was, these devices are maybe akin to voltage stabilizer which we use. It is modulating voltage to our benefit. And sir, Rivia, which arm you use? Is it the same arm which you are feeling headache, or it is the other arm, or any arm? Doesn't matter?
No such recommendation for styling. and you use it on the arm that you're comfortable wearing it on.
But my own feeling is if you use on the same arm, person will have a placebo effect. That's working on the same arm. Anyway.
I must discuss that with the review people and see if they have recommendations.
And
maybe they can enlighten us, maybe there is some information about it.
So it can be used either on the right or the left arm, and sir, no such effect would be seen as the intensity or the electrical impulse which are delivered are just perceivable, but they are not painful, and thus they are the sensitization what you are talking about will not happen.
Anyway, so my point was different. I wanted to know the placebo effect. Was endorphin level or levels of endorphins secreted also included in the study? Whether placebo effect, how much is the placebo effect? I don't know.
So in the trial, as you can see, in most pain trials there's going to be some degree of placebo effect. But as you can see, so they had a treatment and a sham device, right? So it was seen that the most people who significantly responded as compared to the sham device, there was some placebo effect, which is seen in all pain trials.
Corollary to this is our babas. They are using dhaga and some ring or some tabiz. So they act a lot by placebo.
So in fact, after the trial, there was also a study where they actually asked the patients whether they thought they had the device or they had the sham, because they knew they were in a trial, and most people got it wrong. So they weren't sure whether they were using the device or the sham. So even there, they didn't check that.
Just last question from my side. It will be just setting the ball rolling. The medicine failure, medicine intolerance, or multiple comorbidities. These are the main indications for the devices, or you have something else?
Actually, there is no such thing for this device. So what we say is that anybody who has moderate frequency episodic migraines, 4 to 7 headaches out of 30 days a month and above, can consider using these devices. Now, if somebody wants to use it once a month, there is no downside. But like I said, there are two ways to use it. One is an SOS. So you use it as an SOS when you get the headache. And the second is to use it as preventive, where you have to use it every other day. So those 18 will last for 36 days. So sometimes I've given it to a patient for, let's say, 2.5 months, broken the cycle of pain. And while I've kept the oral therapy going, so with the oral therapy also, the oral therapy potentially becomes more efficacious, right? Because you've broken the cycle. You have a bad situation, you're giving an oral medication, it may not act that well. You're helping it with another device, you're reducing the amount of suffering the patient has. The oral medicine also starts taking its own effect. That's right.
Right, sir. That's
I just learned that Dr. Rajashekhar Reddi is actually not well. He's in the midst of a viral episode. And therefore, I would request you to keep your questions short, only about 15 to 20 minutes maximum. And Mr. Dhanendra would like to demonstrate this. Naresh, where are you? Naresh? Can you get your person? He would like to demonstrate the device. So at least see how it is put. Can you just please come here?
Thank you very much to answer, and I'm sure I will not take
no, this is important. This is important.
more than 5 minutes.
Whatever Dr. Reddy has done will be undone unless and until we do this.
Thank you, Dr. Chauhan sir, and thank you, Dr. Rajashekhar Reddi sir. Thank you, Dr. Kalra sir. This is the device. This is the battery, and after this, these are 2 electrodes. So, patient has to tear off this protective cover and keep it into the safe place so that the device could not get dirty. Right? After that, yeah. So after this device should be like put on triceps area. Yeah. This device should be put on triceps area. After the triceps area, this is the bend for the device, so that device will not fall down. So I'll apply this device. That's it. अब यहाँ पर पेशेंट ने लगा दिया. Hello. Yeah. After this, patient has to on this device and connect with the mobile application that namely is Neuromodulation, same as the product. So, mobile में एक Neuromodulation application download करनी पड़ेगी. After that, patient has to connect this device similar like जो Bluetooth watch connect होती है, similar like this device connect हो जाएगी with the. तो यहाँ पर जैसे स्टार्ट आ गया, जैसे डिवाइस को स्टार्ट करते, इट विल स्टार्ट विद द इंटेंसिटी ऑफ 12. इंटेंसिटी मींस द स्टिमुलेशन पावर ऑफ न्यूरोमॉड्यूलेशन. पेशेंट हैज टू मिनिमम गो टू द 20 and above the 20 it should be well perceived, strong but not painful. It should be strong, well perceived but not painful. This device is approved in both the parameter acute as well as chronic. In chronic, patient has to wear the device for 45 minutes every alternate day, and in acute therapy, patient has to wear the device within the 60 minutes, even for 45 minutes. So for both the session will be for 45 minutes, but for chronic it will be every alternate day, and for acute it will be within 60 minutes of SOS. And patient, like for chronic migraine, patient has to wear the device at least for 3 months. Yeah. Yeah, so the device will come with the 18 sessions. So one device will last for 1 month, 6 days, 36 days. The cost of MRP of the device is 16,000, but we are selling to all the doctor, like normally we are selling it 14,000, but for the doctor it will be 10,000. Even this device is available in 1mg, Amazon and everywhere, but you need to purchase the device you need a prescription. Prescription which is MD and above. Yeah. Any other question regarding marketing I can answer. Wish I'll hand over to Dr. Chauhan.
Thank you, Dharmendra, for the demonstration. I think it was very important. I would give it to Dr. Bhaskar to give his perspective. He is also seeing a lot of migraine cases in PSRI. His experience with the device or his perspective on the device.
Thank you, sir. Sir, it was a wonderful talk. I always love listening to your talk on any topic. It's always a pleasure, sir. I always learn something new. So it was a very comprehensive talk, right from the clinical symptomatology to pathophysiology to all the modalities that we have now for the treatment of the migraine. We have really, I do not have basically a question, it's more like a comment. So we have really come a long way as far as the treatment of migraine is concerned. Initially we only used to have some repurposed drugs. Now we have migraine specific treatments like the monoclonal antibodies, and we have commonly Eranumab in our country. I am personally also giving many patients Eranumab, and they have really good response with minimal side effects. One girl who had multiple comorbidities, and she's still in my follow-up. I have given 5 injections so far, and she's doing pretty well. Her preventive medications have come down considerably. So then we have the Botox, as Sir often talks about. The technique is very important. The Botox is very useful. But yes, this Neuromodulation is next level. So it almost compares with the migraine specific treatments like monoclonal antibodies with minimal side effects. As Sir told in different studies, it is comparing equally with monoclonal antibodies. And so we really hope to see this Neuromodulation come in a big way in the treatment of migraine. Sir, have you any personal experience? How many patients?
So, top of my mind, I won't recall. I have about maybe 50 patients or more with this 72. So I have 72 patients that I'm giving this for. I can only tell you that all have come back and been very happy. And in fact, when we started off, obviously as what invariably happened is that the device was more expensive. Over the last 2 years that we've been using this device, slowly the costs also start coming down. It makes it more affordable. And so in many patients of mine, I've had patients who had, you see, the important thing is to recognize a true migraine. There will be certain people who are very genuinely migraine, and they're not calling, and they do have these problems. And those are the ones, if you choose right and treat, they will do very, very well. So I have a young lady again who had renal stones and was given dopamine for a long time. And she done well on the medication, but she just got so much worse because of that. So when we switched to this, any other medication she was completely fearful of. So, and she said, look, I don't want to do Botox, I don't want to do anything, what's the of me? So any medication frightened her with the renal stone trouble. At the moment we gave her this, she got so much better. So there are, one of the interesting thing is that you have more in your armamentarium. That's the important thing. The patients have more choice. And if you use it appropriately for the right people will do it. So, and you will also gain more experience. So I can only tell you that I have nobody come back and tell me, look, this didn't work at all. I have nobody like that. And you, again, see, the important thing is to tell people it's not curative. You're not going to go from a 30 headache day a month to a 10 headache day a month. You might go from a 30 to a 20. Even that we will consider a gain in this situation. So it's important to choose it for patients who are not too far gone. If you choose it for a patient who's got 12 or 10 headache days a month, you're much more likely to give them relief than say that I'm going to save it for the people who are the worst, who are going to be 30 headache out of 30. So it's like stroke medicine, when you give convoluted therapy, you don't want to give it to a person with an analysis of 40. It's not going to work. You want to give it to that person with 10, 12 who will recover to a 0. So I know this is how you have to choose patients, give it to the right people, and people will get better.
Sir, what is your favorite? Between the monoclonal antibodies, the Botox and this Neuromodulation?
So what I do is that I invariably offer everything and I discuss all the options. For chronic migraine, many a time I go with the botulinum toxin. I say that is the thing that I'd like to start with, and subsequently switch to a monoclonal antibody like the Endomab, which is the only one we have here. But the important thing is that you can use these devices as an SOS along with your other preventive therapies that you're doing. So you're at least reducing the burden of taking so many pills. Now when you talk about these things, you're saying 10,000 rupees for 18 usages. Practically it is about a little more than 500 rupees a usage. So many tablets today as SOS, I think some of the tablets that use as SOS will cost 200 rupees. So I think over a period of time it will come down even further. Cost is the only limiting factor in most cases.
Sir, your experience as far as M for cluster headache?
Again, the amount of time that Rajashekhar has been used here is not large enough for me to tell people. Whenever I have procured it, I have to get it from people who get it.
It's not available in India.
It's still not available. So I've used it for some American patients. It costs roughly about, I think about 1,70,000 for a month. So that, and insurance in the US gives it much cheaper. So its cost also is quite, I had patients who were taking this, came here, wanted it, so I gave it to them.
Still oxygen works the best.
Yeah.
Dr. Rajashekhar sir, we have Dr. Manish Sarkar, our psychiatrist friend. He actually wanted to come for your talk, and he's a regular attendee, he's a member of the forum. He's also using the devices for depression in something called as Cmes. I would like his perspective for the larger audience.
Sir, for last almost 4.5 years, I'm using RTMS, repetitive transcranial magnetic stimulation. So I find it very useful in terms of understandably being a psychiatrist. I treat patients of depression, anxiety. Now, since OCD, obsessive compulsive disorder, also have shown very good results with GMS. So my personal experience with neuromodulation is very good, sir. I feel it is a next level experience, I must say that. Now, since depression, anxiety, all kinds of psychological disorders, they carry a very high morbidity with migraine, invariably depression, anxiety has. So I have seen a lot of patients who has a history of migraine, who have been taking medications for migraine, for whom I have administered say 20 to 30 sessions of
TMS, primarily for the psychological conditions, they have also reported that there has been a significant change in terms of migraine also. The intensity and the frequency of the headache has come down. Left dorsolateral prefrontal cortex have been using, sir. So it is a very good experience, I must say.
Dr. Rajashekhar sir, sorry sir. You didn't tell us. Sir, I wanted to ask you, for our physician colleagues, when the patient comes to them first time, our first interaction, can we use it as first modality of treatment?
Absolutely. Can be done.
It can be done?
So it's not as though this is restricted in any manner. You can use it as the first modality of therapy.
Do we need to use certain medications to relieve the headache? Some of the medications which you mentioned?
So some of these medications, like I said, that's the advantage of these things. They have such diverse and completely independent mechanisms of action that it's sort of, going to be synergistic. They're not going to overlap. So if you want to use this along with an oral medication, fine, no problem.
So sir, let me put you through a clinical situation. I get a patient and I have learned from you since 2006 Topiramate is the first drug for treatment and prophylaxis. We can use so many other drugs. And for acute treatment, very severe headache, you give Nextol or whatever treatment. At what stage, sir, at what dosage of Topiramate I should consider REN? 25 milligram, I upgrade to 50 milligram, up titrate to 150 milligram. And exactly how much can we go to Topiramate when we should start considering REN?
So Topiramate is strict. By theoretically you can go up to 400 milligrams a day. But our understanding is that for migraine, that's for anti-convulsant effects. But for migraine, you would imagine that if you're above 50 twice a day or 75 twice a day, it's not like going to help anybody much more. So at that point, that's the ceiling dose, and you would want to consider another medication along with that. So that time you can use this. And for chronic migraine, you have to run both together.
Sir, my patient, when he starts using the device, at one point in time, he is going to ask me, will it cure my headache? So what should be my answer?
Cure, you tell them there is no cure, but there's enough reduction in the burden that you'll feel so much better that this is the best possible therapy in the world. There's no cure for migraine with anything.
Right. Dr. Podar, sir.
This device is only for migraine. Suppose the patient was misdiagnosed by a physician. It was like cluster headache, not migraine. So will it harm the patient or with no effect but no harm?
No harm.
Then the earlier devices, you said one device was used on forehead for trigeminal nerve. The one
That's on Kefali.
vagus. So why one is here for trigeminal, one is for vagus, different devices? What does that mean?
So basically, if you look at the basic, they're looking at something called the gate theory of pain. So all signals are going to the brain from anywhere in the body. And the signals are being perceived as pain in the brain, right? So whether it's a noxious stimulus or a non-noxious stimulus. So over a period of time, if a signal is repeatedly going from a particular area, the brain will perceive that as noxious. So I'm just giving you an example. Suppose you get hit here and the signal is going to the brain because you're having pain here. You knock your shin on a table and you start rubbing yourself. The rub sensation starts going to the brain, overriding the initial signal. Okay. So the gate theory of pain suggests that only one signal can go into the brain at one time. Okay. So now what happens is, any signal, I'm saying, think about it, कोई प्यार से भी आपका हाथ पकड़ेगा ना 10 मिनट के बाद, तो आप कभी छोड़ दो. Because after a while, any signal starts becoming uncomfortable. Now here what is happening is that there is a signal that is already going because of the migraine. You are stimulating another bunch of nerves to counter-irritate that. And that is how Kefali and gamma core and Inura would work to some extent. Whereas REN does not use that, and that's why they keep telling you that we are not going to ask you to push the stimulation to feel pain. We are using another therapy, another mechanism to control pain. But by and large, you look at anything, look at Volini gels. What does it do? It heats up your skin. So the moment you start feeling heat, pain goes away. आप मालिश कराते हो, सर में दर्द होता है, आप ऐसे करते हो.
You get masking effect of.
So that is also important. You must understand that the moment you are masking the initial signal for some time, your brain gets reset and can handle the pain better. So if you don't allow that to happen, then the threshold for pain in the brain keeps falling. See, I'm just giving you an example, sir. If you go into a room every day and scream at somebody, and that person will have palpitations and anxiety, the person will have it when he sees you also, even if he doesn't scream. So the brain is like that. The brain starts feeling less and less stimulation is causing more and more trouble. And so this is how it works.
Thank you, thank you.
Dr. Sajid.
Sir, regarding the electrical modulation, does it have any other effect on the body, like electrical stimulations and other way also, like gut-brain axis in intestines, or control of the urinary system, as well as the electrical activity of heart? I mean, is there have any other effect? Can we benefit from any other way rather than this while we put it on?
So one is that the pulse width and the intensity that they've patented and used are very low. So they're not likely to impair any cardiac function or do any bad effect on any of the other systems. Hasn't been really studied in any other disease to tell you, but there are trials of this going on in fibromyalgia also.
And IBS?
So IBS also. See, the point is that there's, the gut-brain axis, a lot of these conditions are such where there are no biomarkers. Migraine also doesn't have any biomarkers, so there's a lot of it is subjective. So in many conditions where we believe that there are no biomarkers, patients are complaining, there is some underlying abnormality in their, let's say, neurotransmitters or something which is happening which is causing a problem. But this particular device at the moment would not be recommended for any such situation.
Thank you so much. Wonderful.
Sir, can I add here? Neuromodulation, we are talking today for migraine, but it has been proved for and used for overactive bladder, for constipation and so many other nervous functions which are functional, as we say, it is functional, but they have been modified.
Even for constipation.
Yes, constipation.
But even for
IBS. Sir.
Dr. Anil Gupta, sir.
how the efficacy of this in pregnancy? So there are the parts. For the efficacy.
So efficacy also compared to the sham devices that they used with that, it showed the study was predominantly to try to look for safety. But efficacy is also used. I've used it in about 3 patients and I've had reasonable results. See, there is an element of, I see us being able to do something for a patient, which is also important to them. So they feel very good that, okay, there's something which you can do.
Pregnancy where everybody is afraid to do anything.
Exactly.
Have you used any other device other than this? Because there are 5 devices you told.
Right, sir. So I've had samples of caffeine which have come, which I've used for 1 or 2 patients, but not in the manner that I've used this. Because these were the people who came there. Like I said, they told me that I have 72 patients on drones now. So obviously, it's good.
Are they FDA approved?
Yes.
Dr. Mona Lisa, she wants to ask you a question and she wants to benefit by asking that question.
Yeah, actually this is for myself because I have myself been a patient of migraine for more than 12 years now. And I myself am on topiramate and naproxen for 12 years and have not benefited. So I just want to ask that topiramate I have taken up to 100 milligrams a day. 100 milligrams a day, naproxen I'm taking almost every alternate day. It's still not helping. I have tried almost every other prophylaxis. So how will this help? And as in there's a difference between chronic headaches and there is chronic migraine and acute migraine that you said. So Can you please elaborate a little bit on this?
So we divide migraine into episodic and chronic.
Yeah, so there are chronic headaches which also turn into acute migraines.
Okay, so see, for more than 8 days of the month, and you have 7 to 8 days of typical migraine criteria fulfilling headaches.
So if the chronic headache lasts for almost 22 to 30 days, almost every day, it doesn't just go away at all.
So then you're a chronic daily headache,
Yeah.
a CDH,
Yes.
and you're a chronic migraine with MOH, which is medicine overuse headache.
Yes.
If you take more than 10 naproxens a month,
Yeah.
you qualify as a MOH with
So
naproxen.
I have tried to detoxify as well. I was put on steroids. I was on steroids for almost 3 months, and I tried to detoxify by not taking any NSAIDs. And I went back to it. It didn't help.
See, you would require multiple therapies. Like, I would probably give you some botulinum toxin. Botox would be the first way to go to try and break the cycle. And then in prevention, you can use either a monoclonal antibody or a Nerivio-like device, depending on what agrees with. See, so many things that are important. For example, the monoclonal antibodies are not recommended in women who are planning a family. So you have so many migraines who are going to be between 20 and 40 years of age who come to us. So we're not going to use that. So the review has no such restriction. So botulinum toxin again has no such restriction. But if the degree of
So my main concern is every other week, basically I have to take IV medication to control the migraines that I have. I want to get rid of that.
So you're, like I said, medication overuse headache, now you're at that point where you may, like I said, have to use more than one thing. So you're a candidate, like I said, for Botox, you can use.
You suggest that I probably might be a candidate for that?
Yes, you are a candidate for that. And dopamine.
The moment you are out of view, you are first patient.
Sure. Dopamine also causes a lot of weight loss.
It does.
So you're not the best candidate for that.
Dr. Luthria, sir.
I do without anything else.
So how does it interact with a pacemaker? Is there any interaction with pacemaker?
Any?
Interaction with a pacemaker?
With pacemaker, with
No,
pacemaker.
I mean, see, company people correct me on this. So, the moment there is a device which is being used in any other manner, you have a DBS4, you have this, we wouldn't like to use these devices. Because the moment you have a pacemaker or anything else, no, you don't want to use anything else that causes any confusion.
Now, there are people,
So don't use it for people who have any kind of other device.
and is it MRI compatible?
We don't have, it's only a 45-minute wearing thing. You can move it after that.
There are people on prophylaxis, they get better and almost normal. And by 6 months or 2 years or so, the migraine frequency comes back. This device has to be reused after a long gap.
It can be used, there's no problem.
You have used for 36 sessions. Beyond that,
You can continue to use it, just like other migraine prophylactic option. You can continue to use it, there's no problem.
सर मोदी जी आपने कहा कि हाँ मोदी धर्मेंद्र मोदी और उनकी खास बात है, बहुत अच्छी बात आपको लगेगी, कभी आप उन्हें कॉल करेंगे डिवाइस के लिए, वो आपको नमस्ते नहीं करेंगे, वो आपको जय श्री कृष्णा बोलेंगे. ब्यूटीफुल एक्सप्रेशन है. तो ये सर ये जो 36 जो सेटिंग्स हैं जो 36 बार यूज करते हैं,
36 दिन के लिए, 18 के लिए, 18 उसके बाद डिवाइस को ये
18 बार 36 दिन में.
एक मिनट, तो इसकी कॉस्ट 10,000 है.
राइट,
ठीक है.
करेक्ट.
एक मिनट, आज डिस्काउंट है.
मैं आंसर करता हूँ इस क्वेरी को. Just give me 1 minute only.
Listen.
Sorry for the interruption. I'm very sorry. Similar, like one tablet of sleep contains 20 tablets. After the tablet using, we throw out the sleep and we pursue the new sleep. Correct? Similar like this device contains the 18 sessions. Every alternately you have to use. Like one device will last for 1 month 6 days, 36 days. After 36 days, you have to pursue the new one. Like same course. Same course. No. It is for forever for any doctor of this group. The device will cost you 10,000 only per device. Secondly, I would like to add one point in addition to Dr. Rajashekhar Reddi sir. So this device is contraindicated in 3 conditions. One, if the patient is having uncontrolled epilepsy, where the device is not recommended. Secondly, if any patient has the permanent battery operated like things like pacemaker or permanent hearing aid or
DBS.
Yeah, any permanent
Deep wave stimulation.
Yeah, any permanent battery operated device is installed.
And Dr. Reddy said, avoid, preferably avoid.
Yeah, and the third one is PHF.
History of stroke.
Yeah, the third one is a heart failure patient where the device is not recommended.
Sir, history of stroke, please.
I wanted to say that, most of the time when we're choosing these patients, you will rarely ever see that patients with this sort of situation will come to you with a headache, which requires relief. So I would not let you worry too much about these things.
That's right, sir.
Because, these things are there, they will not include patients like this in trials. No? So how can they approve them?
Sir, from the visors table in the audience, Dr. H L Kantur sir has a question.
Sir, actually it is a sympathetic trigeminal nuclear imbalance which causes the migraine. My question is, when we are stimulating neuromodulation, electric modulation in the median and musculoskeletal nerve, how does it affect the physiologically at the brain stem and at the neurocortical region? Because neurocortical region gets inhibitory, so it doesn't. It becomes depolarized, so it doesn't create the inhibitory effects on the brain stem. So we should know the basic phenomenon of this neuroelectromodulation.
So
that I have not understood.
Right. So basically, sir, any stimulation anywhere in your body is going to be perceived in these areas. Be it, suppose somebody is putting a BP cup around your arm and inflating it and you start feeling pain. This perception of that pain is always central, isn't it? The transmission of signals is through peripheral nerves. It will go into the spinal cord, go through the spinal thalamic and reach certain areas of the brain. Now, any stimulation anywhere in the body is going to be perceived by the brain. So, what you're doing here is that you're setting in motion a particular signal which does not cause pain but results in a manner of causing a downstream effect where we know these centers are responsible for what is called central pain modulation, which are typically not working very well in patients with migraine. So that which is sort of lying disused is allowed to get activated, so it comes into play. And once it comes into play, all these are interconnected. So let me also tell you that let me not think that वहाँ neurotransmitter नहीं कम होंगे सिर्फ ये होगा, ऐसा थोड़ी ना है. The entire thing works together. If one thing goes down, everything else will come and fall in place also.
These are neuropeptide is inhibited.
It is.
5-HT.
Yes, all these are also there.
Only 5 minutes before we open the dinner, so I just request your attention only for 5 minutes, please. And Dr. Reddy will also like to leave early because he is in this post. Dr. JPS Tulsi sir.
Once more, great talk, Dr. Reddy. So, friends stand alone or an adjunct to pharmacological treatment. We know it's very safe. See, the adverse effects are hardly seen with this. And I'd like to ask you, how quick does the action start? Does it start right from the first day or what?
So for acute migraine, it's usually about 2 weeks. If you're looking at the preventive,
1 to 2 weeks you said?
2 weeks for usage to show a benefit against the placebo device as early as 2 weeks you can see advantage of this. And for preventive therapy, it takes about 6 weeks to act.
Right. So the International Neuromodulation Society said this should be only used if the patient is particularly this benefit particularly in patients who are refractory to the usual drugs and the drugs may experience adverse side effects to them. So would you say that is true, or can you start this as a first line choice?
It is completely acceptable to start as a first-line choice.
Right.
If we sit and talk to every migraine patient about the side effects of every drug they take, every patient that you've given amitriptyline for will say that I have sleepiness. Every patient with divalproate will say that I have weight gain and hair loss. Every patient with a cybelium will say that they have mood issues. So it's invariable. We don't ask these questions a lot of times. So a lot of times when we're not asking these questions, we don't know. But if you're talking about side effects, lack of efficacy and lack of tolerance, both are important. No?
Right. So triptans, as we know, are the gold standard treatment in migraine. Do you have any concerns in triptans causing de novo coronary vasospasms? They are exceedingly rare, but you have a family history, you have a CAD, probably you might not like to use them.
So, see, in active coronary disease, active cerebrovascular disease, you would not use. So they act on the 5-HT1B presynaptically and 1B receptor. Now we have lasmiditan, which is a newer 5-HT1F.
That does not cause vasospasm.
Doesn't cause vasospasm. So if you're concerned about that, and you want to use a medication that acts in the same manner but does not affect that, then you choose lasmiditan.
Absolutely. My last question. A real world scenario. A 51-year-old lady comes to a physician like Dr. Chauhan, who is a diabetic specialist. She has type 2 diabetes. She is also morbidly obese. She has OSA and she has a headache for the past 1 year, chronic daily headache. As ma'am said, where is she? She's gone? Okay. CDH. Every day she has a headache for the past 1 year. See, physicians like us probably thought that this is a post-concussion syndrome because she had a head trauma about a year back. She was on metformin, 500 milligrams BD for her diabetes, and recently some doctor, like one of us, switched this patient to sitagliptin. An astute neurologist like Dr. Reddy would probably take a history of a drug like DP4 inhibitors and say, this is the cause of the headache. What do you say, sir?
So, looking at the drug list is very important. And if a person comes and says that there's a new onset headache,
not
a burden of headache or a new onset headache. At a certain point, if you see that happening, you must see if there's a trigger, if there's a drug which was added, if there was a life event, so many things, sometimes dietary changes happen.
How often do you see DP4 causing headache?
Not very often.
It's about 1%.
Not, I haven't, maybe they don't come to me.
So this is a real world scenario. Thank you, sir.